Thank you so much for joining the show. I appreciate you being here. I'm going to introduce you, Dr. Leonard Weinstock. Nice to meet you. Thank you for joining today. You were born and raised in New York and moved to St. Louis in 1985. You received your BA magna cum laude from University of Vermont and his medical degree from University of Rochester School of Medicine. He completed his postgraduate training, including serving as chief resident in internal medicine at Rochester General Hospital. He went on to complete his gastroenterology fellowship at Washington University School of Medicine in St. Louis. He's board certified in both gastroenterology and internal medicine, and is currently president of specialists in gastroenterology and the Advanced Endoscopy Center in St. Louis. You're also an investigator at the Sundance Research Festival and clinical research practice, and you've led numerous independent and pharmacological studies. You've dedicated your career to Mast Cell Activation Syndrome, SIBO, restless leg syndrome, Ehlers-Danlos syndrome, and the role of low-dose naltrexone in complex chronic conditions. I appreciate you so much for being here. Thank you so much for joining us. It's an honor to have you.
Thank you so much for the invitation. Thank you.
All right. For listeners who are new to this, can you please tell us what exactly is Mast Cell Activation Syndrome and why it can be so misunderstood?
Absolutely. Well, MCAS, Mast Cell Activation Syndrome, and we'll just call it MCAS hereafter, is a common disorder, roughly 17% of the population, with a 5-to-1 ratio of women to men, of a hyperimmune disease. And what I mean by that is that there's a mutation, a series of mutations that can occur at the controller gene of this most important immune cell. Now, this immune cell, the mast cell, is so important. It's the captain of the immune system, if you will. It controls how much activity of inflammation or blood growth creation occurs to control an infection or a bone fracture or a burn, for instance. When somebody is born with this immune disturbance, with a mutation, you get a series of medical disorders and symptoms and syndromes throughout one's life.
Wow, that's incredible. I didn't realize how much of the population can have it. You said 17.
Yes, this is on the basis of an article from Dr. Molderings in Germany, 13. And Dr. Molderings discovered mast cell activation syndrome in 2006 and then did a great paper in 2007 demonstrating all the different mutations that occur in the mast cell in this disease.
That actually brings up something that I was reading about. I believe that there's a consensus 1 and consensus 2, if I'm correct, on diagnosing MCAS. Can you explain, like, in layman's terms, what that means for us people that don't know?
Well, I'll tell you, this is a big issue of contention. Big. Mm-hmm. So Dr. Molderings and then Dr. Afrin, who joined his research team, and came up with their own criteria, which have been substantiated in an article in 2020 and now in an updated article coming out soon in 2025. And basically, there's basically 2 ways to have criteria to diagnose MCAS, the easy way or the hard way. The easy way is using Dr. Moldering and Afrin's criteria, which were developed and basically have numerous symptoms and systems involved with typical mast cell problems. B, demonstration of 1 or more chemicals that are produced by mast cells. C, the response to mast cell-directed therapy with improvement in symptoms. And then D, exclusion of other disorders that could resemble it. The difference comes with one little bad word called tryptase. And I think your listeners will know the problem with seeing an allergist, going to the allergist's office, getting the blood test for tryptase and being told it was normal, therefore you can't have MCAS, goodbye. And this is what's going on. So the consensus 1 criteria, which came out around the same time, but was not based on data, where ours was, and now I say ours because we have the International Society of Mast Cell Activation Syndromes that was created to deal with things like this, and we use the consensus 2 criteria. We should have published earlier and called this consensus 1, but The other group of allergists that came out of Austria came up with their consensus one. And basically, what it does is it curtails the number of patients that can be diagnosed with MCAS. And the reason why is the symptoms are the same, except for the fact that they really require anaphylaxis, which we don't. And B, that's the testing that the tryptase level is elevated or goes up during an attack by a certain degree. And C, it's very similar to ours, that patients get better with mast cell-directed therapy. So we're having trouble with A and B. A, you simply don't have to have anaphylaxis. And B, you should be able to look at other chemicals produced by the mast cell and not just tryptase, which is never is rarely actually elevated in our patients and rarely undergo that second testing during an attack within 4 hours.
That is so important. I've met a lot of people that their doctor refused to diagnose them with mast cell because their tryptase was normal.
Yeah, tryptase is very specific for mast cells. So there's, for instance, tryptase is only made by mast cells, and it's a great test for systemic mastocytosis or cutaneous mastocytosis. SAM's systemic mastocytosis is a malignancy acquired in adulthood, whereas in general, 99% of mast cell activation syndrome is acquired at birth, and you start getting symptoms that are present in childhood, gets worse during teenage years, and then blossoms into a whole spectrum of symptoms, syndromes, and diseases in your adulthood. But it's still, guess what, Kimberly, it's still only due to one aggressive, uncontrolled mast cell.
Let's say children, adolescents, teens. Will you see normal symptoms in each age range? Adolescence, and then you see things in adulthood?
To the most part, yes. Let me give you typical examples. It's very common to have chronic constipation as a child, colic as a baby. Most patients are not going to know about that unless their mother complained to them. But, because colicky baby is tough. But guess what? That could be one of the first symptoms of MCAS. So sensitivity to foods, food reactions, rashes, hives, and gastrointestinal problems are significant. And then a little bit later, headaches are common. Bruising may be present, growing pains, which is one of the form fruits of restless leg syndrome, may be present. Sensitivity to insects with big welts, common in childhood. As a teen, if they have infections, viral infections, it takes a lot to get over, especially infectious mononucleosis, which, if they have it, can accelerate their condition. Menses is a big one. So severe painful menses, stay-at-home type menstrual periods are really common. And then those hormones are magnified at pregnancy. And in fact, there are some spontaneous cases of a mast cell activation disease, such as postpartum. And this week I saw two women on the same day that immediately postpartum, within a week, both of them developed mast cell activation syndrome type problems, and one developed POTS before that with a different pregnancy. But, things like restless leg syndrome in adulthood is common, and some get it as a teen. The neuropsychiatric disorders, of which restless leg syndrome, of course, is neurological, 40% of MCAS patients have that.
Wow.
And that contributes towards poor sleep. And then ringing of the ears, tinnitus, is a neurological disorder. 60% of patients have tinnitus with MCAS.
With people with MCAS, does it affect all the systems in the body?
Different systems, constitutional, HENT, that's otolaryngology, headaches, and then in the HENT, you got itchy eyes, burning mouth, stuffy nose, runny nose, eye irritation, and of course tinnitus. Then you go down to cardiac type symptoms, gastrointestinal problems, neurological disorders such as headaches, brain fog, neuropathy. Then you've got skin disorders, which are really important, but don't always occur. So the skin disorders that are critical in terms of looking for mast cell symptoms would be itching, where there is no rash, itching with rashes, hives, angioedema, swelling around the eyes, especially during attacks, edema, neuropathy in the face as well. Then hemangiomas, these little cherry red angiomas on the body, usually the belly and the chest, that enlarge and itch during attacks, cystic acne and other kind of atypical acne that starts during an attack, and then dermatographism, where you scratch yourself and you get these red marks or white marks, and then nodules that form from fibromas or lipomas or Derkim's disease.
My fiance is my biggest advocate, and so he read your research paper, and there's a questionnaire. I think it's called a primer for the gastroenterologist.
Yes. Yeah.
Is there a way that people can find that questionnaire? Because that questionnaire, I've never seen anything like it, and I filled it out, and I was like, this is amazing.
Yes. Well, all of my papers, is including, which I think one of the most important ones, and I'll tell you why on a personal level, I think it was one of my most important ones. That is Appendix 1 in the neuropsychiatric manifestations of MCAS in 2023. So if you just Google Weinstock, MCAS, depression, you'll come up with my articles and colleagues' articles in 23 and 25. And 25 has got Appendix 1, which will show you the questionnaire, which you can hand to your mother, to your sister. If they have weird diseases that nobody's figured out, there is a 70% incidence of having a relative with MCAS who has MCAS.
That's incredible.
Yeah. And I can tell you the personal reason why this is so important to me. First of all, it was left off the questionnaire originally, and it's actually still not on the questionnaire now, but depression, anxiety are so common in our patients. And so I was giving advice to my daughter because her son had panic attacks, and it was either panic attacks or abdominal pain or nausea that got him going to the nurse on a regular basis, the school nurse on a regular basis. And I said, okay, maybe this is POTS, Leah. Just give Max the H1H2 blocker and see if that provides some degree of therapy, because it's a simple thing that anybody can take. So, famotidine or Pepsid is the H2 blocker. H1 blocker would be your Zyrtec and Xyzal, etc. And patients can get dramatically better without even being tested. I've had irritable bowel patients come in, just H1H2 blocker. They stopped the naltrexone. They didn't need it, and their IBS was cured. And same thing with a reflux patient. Couldn't get off of PPI, Prilosec. Patient had pretty significant seasonal allergies. Gave him the H1H2 blocker, cured.
Wow.
So poor Max. So I decided enough was enough, and I would, come down to Nashville and talk with Max and go over all the symptoms. So I asked, what about bruising? Rolled over on the couch and say, I got all these bruises on the back of my legs, and I don't know why they're there. But I do, because bruising is very common, and the mast cell makes heparin, which is a blood thinner. And no other cell in the body does that. So bruising is common. And then he was scratching his palms, and that's very unusual. And then we talked about the fact that he lost a lot of weight, he hadn't grown about an inch. And I talked with the pediatrician and the Vanderbilt pediatric gastroenterologist, and had him do the appropriate tests, which we might talk about later. And he's had dramatic improvement, significant improvement. Now can eat everything. There's no issue with food reactions. There's no bruising anymore, no itching. Has gained back all of his weight. It's dramatic. And, pretty special when you can learn a skill and use it on a home, somebody who you're related to and is so important to you.
Wow. I think it's a beautiful story that you listened to Max and were able to help, and you were like pinpointed, and you could ask all these questions, and that he feels better. I hope he continues to feel better. You talked about something really important. I'm not sure if you are on TikTok. People talk about women before their period, and a lot of people are like, try a Pepsi. And that made me think about when they have mast cell flares before their period, and maybe that's what it is, or instead of like, it's just hormones.
I actually practiced that thought. So Dr. Afrin and Lila Rosenthal wrote a paper maybe 5 years ago on using Benadryl douches before or with the onset of the period. And so I've been giving vaginal Benadryl suppositories made up by my local compounding pharmacy to start with the first day of the period, and do it at night so it can just dissolve and get to the cervical and possibly the contact within the uterus so that it decreases the driving force of estrogen. So it is a driving force for mast cell activation. There's a receptor on the mast cell for estrogens that activate the mast cell, and the mast cell has 300 receptors, which some activate and some deactivate the mast cell. And the mast cell can put out 1,200 chemicals, and we can really only measure 5 or 6. So there's a lot to be learned as far as diagnosis. There's an issue of consensus, which is a really critical problem for the patients. There was one paper written by an allergist said that if we didn't have stringent criteria, our offices would be flooded with all these patients. And how would we be able to practice our allergy and seasonal allergy practice and our asthma practice? I mean, those are the no-brainers. It takes some thought and reading the literature and learning more about MCAS. And it's the hope that someday it'll be something that's covered in medical school. But it's not.
I've been diagnosed with premenstrual dysphoric disorder, and so I wonder if a lot of women are just experiencing mast cell flares or anything before their period.
I have a slide that I show with an umbrella and all the syndromes listed, and it basically, the umbrella covers all the symptoms printout, and basically MCAS is on the umbrella, and basically if you've got MCAS, you could have pelvic pain disorder syndromes. You could have Ehlers-Danlos syndrome and POTS, migraine syndrome, fibromyalgia syndrome, which is for most patients a BS diagnosis. And you could have chronic urticaria syndrome, tinnitus is a syndrome, restless leg syndrome, and so forth. So if you could come up with diagnosing the one disease that explains everything else, then it's easy.
Would mast cell flares look different in like premenopausal women and menopausal women?
Yes. Approximately 10% of my female population of MCAS patients are in menopause, and their symptoms seem to lessen, but they still have some of the syndromes, irritable bowel and others, but they are less affected, and they could tell you, though, that when they were, trying to raise their family, they really were having fatigue and brain fog. I just saw this woman yesterday who walked out of while we were standing up and going over things, and she said, the first baby has severe fatigue, second baby, much, much worse fatigue. My doctor just says, well, it's simply hard to be a mother.
That's horrible. That's horrible.
That's horrible. Right.
Yeah.
Medical doctors are horrible because they're taught to learn their silo, become specialists, learn their silo. If they're generalists and family doctors, it's a problem because they're expected to do so many things, check your seatbelts, that you're wearing seatbelts, check for depression. And guess what? Depression is very, very common in MCAS, well over 30%. So in that neuropsych paper, you'll see that at least 30% of patients with MCAS compared to controls are affected.
It's just amazing to see someone like you that is fighting for patients and looking deeper than just, hey, here's something, try this, or oh, it's just this, being dismissed. So thank you on behalf of everyone for doing that for us.
It's funny. I don't remember being taught one thing in med school about syndromes. We learned disease, we learned hypertension, and we learned renal failure and cancer, but we didn't learn syndromes. And then I went into GI practice and joined a great doctor who maintained an internal medicine practice his whole time. And he said, he wanted me to do internal medicine and GI at the same time. So from 87 to 2000, I did both. And I saw so many patients who the rheumatologist diagnosed with fibromyalgia and restless leg syndrome. Virtually nobody even diagnosed it, but they had it when you talk to them. And so many women who were had bruising. I thought that is like interesting. Why? And the reason why is MCAS. And then in 2000, Katie Couric had her colonoscopy live on TV, and then everybody was able to get colonoscopy utilizing their insurance for screening. Before there was no screening, only symptomatic colonoscopy. And then I had to drop internal medicine. But it was very instructive and dramatic. And for a long time, irritable bowel syndrome really, really was amazing because at that time, 15% of the population had IBS. Well, that's like an epidemic, and as of course is MCAS, but so many of the IBS patients we couldn't really help. And in 2000, doctors at Cedars-Sinai determined that bacterial overgrowth was part of it. So SIBO then is something I got turned on to, small intestinal bacterial overgrowth. Started applying this to the syndromes such as pelvic pain syndrome, chronic prostatitis, interstitial cystitis, restless leg syndrome, rosacea. And it turned out that when patients had both SIBO and MCAS, you had to look for it and treat them to deal with the bloating issue.
How do you heal MCAS if you have SIBO? Like, do you have to heal the SIBO first, or do you have to heal MCAS? Or are they kind of like married together in a way?
Well, first of all, SIBO is an activating factor. I used to give lectures, and there was a cartoon that showed the bacteria on the outside, and you saw the inflammatory cells on the inside, and the inflammatory cells on another slide that I would show activating the nerves of the intestine. And so you've got to do everything at the same time. So you want to dummy down the effects of SIBO by treating with antibiotic and sometimes prokinetics and sometimes with permeability treatments and sometimes with motility therapies. But at the same time, you want to deal with the underlying problem of mast cells. And most mast cells live in the GI tract, especially the duodenum and the ileum, small intestine. And you want to deal with the sensory nervous system that's being inflamed as well by treating with mast cell stabilizers. And that the stepwise approach for that is detailed in the primer for gastroenterologists, although we have new exciting data that I can share with you if you'd like.
Yes. Before we actually do talk about the trifecta, which I do want to get to, I want to make sure that are the symptoms still the same in men? Do you still see mood changes?
Yeah, I would say yes. Obviously, there's no monthly swing, but pretty much the same. Yeah.
I'll make sure. I watched your documentary, Understanding the Stealth Syndromes. Can you go more into that for us?
Well, let's see. Tested in 19, I gave a lecture along with 50 other people attending the Mast Cell conference. And after I gave my lecture, I'd heard other lectures, and then I, spontaneously said, us 50 people can't take care of all of America. We have a different viewpoint of what MCAS is, and it's totally different than the allergist. So we need to do something to increase awareness, so maybe like a documentary. So somebody said, that's a good idea. And then I said, okay, well, let's meet at the break, and then we can determine where to go next. So people were really excited and interested. One of the doctors, Dr. Dempsey, who's with Dr. Afrin in New York, said, I've got a patient who's a documentary filmmaker. So she called the patient. It turns out that she gave her the price of $1 million to create a documentary. And we said, oh my God, that's something that we can't do. And 2020 happened, and guess what that was?
COVID.
COVID. And so it was like, oh my gosh, now we're just living in a new crazy world. And so it was dropped. And then in 24, I was at an LDN conference, and I talked to Linda Ellsgood, who runs LDN Research Trust.org, a really important one. So that's ldnresearchtrust.org. And that's actually where you can find the documentary. And I said, we need a 501c to collect, and we have to have people. And I know you've made documentaries and they've been successful. And she says, speak no more. Let's do it. She goes off and running into the area where all the drug companies and pharmacists hang out, and she said, I found our first donor, and it turns out he didn't donate. We started our affair and got about 180,000, and with people donating their services and time, we made this documentary, and I think it's good, and I'm very proud of it. I put a lot of hours into it, and I got to tell Max's story, and got to talk about things that we're talking about today, along with Dr. Afrin, Dr. Dempsey, who concentrates on the Lyme-borne, tick-borne diseases, and another doctor who's a specialist in POTS, and another one who's a specialist in EDS.
It was amazing. I love the fact that you brought on real people and talked about what their life was like before and after naltrexone. Can you actually mention what low-dose naltrexone does and what it does, like what it is?
Sure, absolutely. Well, I've been prescribing it since 2005, and the pharmacists, the compounding pharmacists who are still in practice at Genesis, came in and said, would you be interested in learning about something that decreases inflammation, and knowing that, inflammatory bowel disease, you can only get so many people free of the disease despite, $20,000, $100,000 drugs. I said, sure. And in fact, I would use naltrexone for refractory inflammatory bowel disease patients. And what it does, it decreases the activity of the endocrine cells that make endorphins for a period of time of 6 hours. And during that time, the body senses that they don't have enough endorphins, which are just normal circulatory phenomenon that we have on a circadian basis. And during that time, the cells gear up to make more receptors and are gearing up to make more endorphins, but they can't get rid of those or secrete those endorphins until the naltrexone wears off. So when it does wear off, you get a surge of endorphins, which reduces T cell, B cell, and mast cells. You get also the effect of having that naltrexone sitting on top of receptors that activate cells that make inflammatory chemicals. And inflammatory chemicals will excite the mast cell and activate Mast Cell Activation Syndrome. So you get pain relief from the endorphins, and virtually everybody, it seems, with MCAS has pain somewhere, whether it's bone pain, headache pain, nerve pain in the extremities, abdominal pain, and of course muscle pain and joint pain. So the fact is that we want endorphins to help us naturally, and we can get a boost of this. So it's not like you're taking a narcotic, you're taking an anti-narcotic that does this trick in your body.
Can they ask their main primary care provider?
So if they're in one of the 3 or 4 states that have naturopaths, go see a naturopath. They're great. And they prescribe naltrexone. They like not prescribing drugs, but this is the one drug they love. And it's the least drug I ever prescribe, because we're using tiny amounts as opposed to the full dose. The full dose is used to prevent alcohol and narcotic abuse, used in micro quantities, either 0.1 or 1 milligram and up. You're using it to create this anti-inflammatory phenomenon. So as I said, naturopaths love it. All the functional doctors love it and use it. the regular old GPs or EMR blocks them from prescribing off-label and microdosing. And there's this LDN Research Trust that tells you who is prescribing in what states. And then there are also national prescribers who have multi-state licenses that you can get a prescription. And generally, you go to a compounding pharmacy to get it.
Can someone get it as like a rub, or does it have to be like a
Yes,
pill?
you can use it as a cream. It's a little tough. The compounding pharmacists have a little bit tough with that, but there is that's available. And then liquid, absolutely available, both in olive oil or water, and it lasts a little less. And then there's some people who make it up on their own in water. They get a prescription for 50 milligrams from their doctor, and then they dilute it. And but the problem with that stuff is that it's not always high quality, and so the dosing may be a problem. And there's also a dermatologist who's got an article that he gives the recipe for low-dose naltrexone in a published journal. I think the Journal of Academy of Dermatologists, and so there's that as well. So you can look for that. But this is a compounding pharmacy. The advantage is A, it's relatively inexpensive. B, it's quantity specific and certified, and they get their resources from the places that make the naltrexone that other companies use to make the high dose disease directed naltrexone.
Sounds like many patients with different types of maybe ailments can be helped by this, and which leads me into the question, cell syndromes and the trifecta, MCAS, EDS, and POTS. Can you talk a little bit about that?
Yes. Well, statistically, if you look at a group of mast cell patients, about 20%, 22% have EDS and POTS. On the flip side, if you look at a group of POTS patients, 66% have MCAS, and the POTS is thought to be due to the MCAS because the mast cells deposit their cells in nerves, in between nerves and capillaries. So they get excited, they get chemicals activating, they gets absorbed, and it goes to the circulation. And a lot of MCAS patients will have fainting or near faint. But if it's really, really bad and it's big deposits, then you'll get POTS. EDS is interesting as well. It's if you ask EDS experts like Dr. Marcus in New York, who also has a new way to administer naltrexone, which was published. So if you Google Norman Marcus naltrexone, you'll see his latest journal article. And anyway, he says, as does another famous doctor, Dr. Jim Harris, that 85% of their MCAS patients have 80% of their Ehlers-Danlos patients have MCAS. So a big part of MCAS is to treat, with mast cell-directed therapies. Mast cell-directed therapy does help EDS and many cases of POTS.
Do you see a lot of patients get POTS and things like that, especially after COVID?
Yeah, absolutely. Yeah. So there's an article, again, Google MCAS, POTS, and long COVID. And that's our article showing that the symptoms of long COVID are virtually identical to untreated MCAS. And then other important articles, you can Google and get long COVID POTS and see the validity of using SSRI antidepressants. And even, Googling long COVID, MCAS, and nicotine, you'll see some nice articles how nicotine patches can be helpful. People do with long COVID get better with mast cell-directed therapy, and the fact is that somebody has lifetime MCAS, they can then get a bad case of COVID and then spiral down and have a hard time fighting their way up, or they could develop long COVID along with their long MCAS and be struggling. Yeah. Wow. That's why this new treatment I'm working with, I'm very excited about.
Well, let's hear it. What is it? What is this new treatment?
Okay. It's the GLP drug, tirzepatide in microdosed amounts. The
Wow.
lady come in with fibromyalgia, bedbound, toilet-bound, couldn't take care of kids, lost her job, on the toilet 12 times a day with diarrhea. She saw a number of doctors, told her that she had fibro and it was also psychosomatic. She saw me starting about 2 years ago. I was trying her on a number of different medications and they didn't really work that great. Some, but not great. Then I put her on tirzepatide and she came back for a follow-up and she says, I have no more of A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P symptoms. She had 15 different symptoms that were completely gone. And she felt great. And she was now felt like she was able to get a job and take care of her kids. And it was almost chilling, if you will. And certainly she came in with this big smile and then was weeping after telling this story and saying, why didn't any other doctor believe me?
Wow. Is this the same dosing as you'd see people take it to lose weight?
No,
Things
we're
like that.
doing a microdose, and we had a case series, the first one of 47 patients who were failing mast cell therapies, average of 13 different medications, who added low doses of tirzepatide or semaglutide. Generally, the compounded type, if they didn't fit the criteria, or some of their doctors actually gave them this for obesity as well. And so 89% of these patients had clinical response, meaningful clinical response, which is dramatic because, for me, with naltrexone, I was seeing a 60% response, and that's in the LDN book 2. It's, really dramatic. And so just find something, any drug that you
Yeah.
give to somebody, and if you look at their statistics, it's about 8 to 10, maybe 12% better than placebo. And that's a winner and allows somebody to get FDA approval. Well, of course, we didn't do a double-blind placebo-controlled patient study. We
Mhm.
did try with Lilly to try to get that, but unfortunately, they would not support a study. So unfortunately, that's the problem. Okay, so here it is. Afrin, Weinstock, MCAS, GLP-1. That'll give you the article and gives you the article, and then a table is hinged attached to it that expands the course of action of the 47 patients. But each of the investigators the 6 doctors put a paragraph in of typical clinical scenarios, which are illustrative cases that are pretty cool, and including one that I saw, but not this most recent one, who was pretty dramatic.
That's exciting. I didn't even know that could be used for something like this. Are you less likely to get the huge side effects?
So I think the microdosing is critical. Now, the thing is that when I looked at the data and pierced things out, GI symptoms were common. However, we had 6 doctors doing their patients 6 different ways. So some started off with a higher dose, but when they ratcheted it down, the nausea and constipation got better. So we're now marching through my patients, 60 new patients who never had GLP-1s are getting microdosed, and I'm in the data collection stage, so I can't tell you what's happening yet. I'm waiting for more people to send their questionnaires back, and I'm excited to see what things will be happening.
This is excellent that you're doing the research and you're testing out this type of thing on patients and kind of getting a real-time feedback on if it helps.
Thank you.
Do you have any advice to give to the people that are the loved ones of the people that are going through it? How can they best advocate? Should they go to the appointments with people?
They could take an hour out of their time and watch the movie together. That's number one,
Absolutely.
because
Yes.
we do deal with that, right? You saw it. Lived through one guy with POTS, Steve. He couldn't deal with discussing it every time a relative or a friend came up. So he would piece it out. He would tell, his most closest person, his wife, to do the speaking for him so it would get out there, but he wouldn't drag himself down into it, but he was getting better. But nonetheless, his was unusual, but he didn't really want to talk about it too much. But the others, especially Amy, she was glad to be able to tell her relatives what was going on, how to understand her better, so that's important. So then there are people whose family members, whether it be the father or the brother or the uncle, say, agree with the doctors that tell that this person can't have 50 symptoms. You're just making it up. And guess what? You're not making it up, but you need to have support from your loved ones. And so you can give the article, give a link to an online YouTube, and I have a bunch of YouTubes, and get people to believe you that way. And then finally seek out the help that's going to get you better so that they see you're not in bed the day that everybody's there for the family reunion. You're able to participate, and then they'll say, wow, you look different. And I yesterday saw a woman who had BII, breast implant illness, and nobody believed her, and I sent her for surgery to get rid of all the silicone, and she was helped, but with the GLP-1, it really made her look so much. I mean, she looked healthier, her color looked better, and so forth. And she's got a very strong advocate in her husband. The moms are the big ones. Sometimes, like the patient with fake fibro and depression and diarrhea that was bound to her bedroom, she had, difficulty talking to doctors and writing down or clicking boxes on her review of systems. And she would say, well, I shouldn't even be writing this. The people are thinking I'm crazy. And so this is a big, big problem. But the crazy symptoms, if you will, are not crazy. So those with panic attacks, ADHD, OCD, depression, anxiety, dissociative problems, I've seen, even suicide attempts, which are common in MCAS. This is not just your brain. This is your brain on chemicals. And these chemicals are your mast cell chemicals. And so you are not to be blamed for these neurological disorders. And my point is that psychological disorders always comes with a baggage. And I'll tell you one more story. A patient who's 60, postmenopausal, she was having MCAS GI symptoms that wasn't responding. So I gave her a medicine that normally is given to sickle cell patients. She called me back and said, my GI problems are better, but was this supposed to get my anxiety and suicidal thoughts and depression away? I said, well, I guess so. Yeah, certainly. And she said, well, I've had 40 years of depression, and every single day I've thought about suicide, and now I don't feel that way.
I have never heard before reading your research that mast cell could cause this kind of thing.
Yeah, I'm going to present this at a meeting in Spain in April, so I'll talk about this in front of hopefully a lot of doctors that will then spread it around Europe. Europe, the only place that believes in MCAS is Dr. Moltering's University at Bonn.
I want to read the paper about them. I think it's neuropsychiatric symptoms in mast cell patients.
There's two. The one in 23 gives that patient's story and 7 others just as a exemplary illustrative cases. And then the statistical patients study, that was 25, that showed how important it is to include asking questions about these neurological disorders and psychological disorders.
Thank you for being a voice for that, because I have dissociative identity disorder, and I definitely can relate to some of the stuff you're talking about.
I took this woman into my practice, referred by another doctor who had severe depression and suicidal thoughts and cutting behavior before I saw her, but all over her arms were the cuttings. And she said she was suicidal, and I talked to the psychiatrist, and so we tried a few more things, and she said she had dissociative phenomenon, which is something that I was not aware of before, but read about. Kind of living on her own. Her family really kicked her out. She lost her job and so forth. And she came in, oh, maybe a month ago, and she says, "Can I give you a hug?" And so I came out in front of my secretary, and she gave me a hug, and she says she can't believe she's working. She has no depression. She does, however, did find that the psychiatrist found the right drug that combined with the mast cell treatment. But I mean, that was just so amazing.
That's a breakthrough. Absolutely.
Yeah.
That's incredible. I have one major question before we end. I know we talked about breast implant illness. Can mesh for hernia surgeries, can they cause mast cell reactions?
Absolutely. So any foreign body that goes in, one of my patients with trigeminal neuralgia and neuropathy who got better dramatically, completely with naltrexone, had persistent mast cell symptoms and had the implant for a long time. And I said she had to get it out. And so that was a big discussion. Another patient with the breast implant, she said it defined her. She didn't want to, it was 13 years, but she didn't want to get rid of them because of her looks. But the patient had a dermatologist who had mesh put in. She was hard to treat and had her taken out, had her get taken out by the general surgeon. She got dramatically better, and I rarely see her, maybe once a year now. And so implants are really, really, really big. So they could be plastic, they could be metal, they could be your teeth with respect to implants. And then the other big one to think about are the clips for surgery. So I have had a couple of patients who have worsened their gallbladder pain after their gallbladder was removed because they were allergic to staples. So one found a doctor or surgeon in Texas that would take them out and replace them with plastic, and another one is still struggling to find a doctor who will do that because they don't like to.
Yep. I have the same thing because I have Ehlers-Danlos syndrome, and I had a previous hernia surgery with no mesh, and now I have two more in the same area, and no doctor wants to treat me without mesh. So it's hard to find a doctor that believes the mast cell thing. Before we close, do you have any new things coming up? Are you excited for any new research or testing that's available, and a message that you want to give people that are fighting for a diagnosis?
Absolutely. So I'm here in my office, and I'm working on a protocol to try to get a grant to do a therapeutic trial of fibromyalgia with ultra low dose naltrexone plus or minus low dose or microdose GLP-1 therapy. And all these people walking around with these stupid diagnoses of fibromyalgia when it's really MCAS is just maddening. And just like my patient who I told you A through P went away, that's real. And you just can't make that up. And so the mast cell is at the heart of many cases of fibromyalgia, and all the drugs used for fibro are bad and/or duloxetine, horrible, difficult to get off. Duloxetine is Cymbalta, and there's even a website support group. Cymbalta hurts more than fibromyalgia, but that basically shows you we're doing a lousy job with but all the symptoms of fibromyalgia are also present in MCAS plus. lw@gidoctor.net. I don't see patients out of the state. Sometimes I'm able to refer to people who are compassionate. I strongly believe in naturopaths because, I've given a lot of lectures to naturopaths and they're always receptive because they always are seeing these difficult patients who want something less intense than meds. And basically, if you look at diet, gluten, dairy, histamine, plus individual triggers that can get better, by the way, once you're treated. You could treat with my step 1 therapy, which is something that a naturopath can do, and that's simply H1, H2 blocker, vitamin C and D, Leodonin or quercetin, which is a flavonoid, which is a good food product that is in a pill and decreases mast cell activation syndrome. And then finally, one prescription, which is LDN. And LDN can be prescribed on the microdosing pattern by Dr. Marcus or by the standard practices that other doctors use, as I do and still do, but I did and still do. Anyway, more intense things, are written about. And so Google me up, so to speak, see my YouTubes, especially this great one that you're seeing now. Spread this one to your family members who don't believe you, but want to believe you, but they just can't.
Thank you so much. I am so
Yeah.
grateful for you. Thank you for advocating for us, and I appreciate your time today. Thank you so much, Dr. Weinstock.
Thank you, Kimberly.
Thank you.